Hello, I'm Elise Lauer, the director of the University of Cincinnati Cancer Center Comprehensive Breast Cancer Program, and it's my pleasure to introduce you today to Dr. Sarah Medek, assistant professor in the Department of Radiation Oncology. As part of our continuing series, she's going to review and talk about reducing radiation doses, what we learned during the pandemic. Sarah.
Thanks so much, Dr. Lauer. So I wanted to start out by talking a little bit about radiation and why we use it. So radiation is a broad term that describes the type of cancer treatment that uses high energy particles to kill cancer cells. So we can do this in two ways. We can do this using a source outside of the body, something similar to external beam radiation, or we can use this using implantable radioactive sources, which is brachytherapy. I oftentimes get asked why radiation has to be given in multiple doses. Why can't we just give one high dose radiation and be done with it? And unfortunately, except in very certain cases, radiation needs to be spread out because of how toxic it can be if you give a large dose of radiation. So we divide a dose into multiple fractions, which can help spare normal tissue by giving it time to repair damage and repopulate the area. In certain types of cancer, we also think this may increase the damage by allowing some of those cancer cells to enter a state in which they are more sensitive to radiation. Obviously, we need to be careful too, because as our normal cells repopulate, we're also worried about any cancer cells repopulating. And so the regimens that we use have been very widely tested throughout time. In breast cancer, radiation therapy is used to help eliminate any cancer cells that can be present after surgery. So in doing so, this helps reduce the risk of a recurrence and can help people live longer. In early stage breast cancer, we use whole breast radiotherapy, which can be done with or without what we call a boost, meaning an extra dose of radiation to the area right around where the surgery happened. We can also do accelerated partial breast radiotherapy, or APBI, which is a smaller area right around where the surgery happened. And we'll talk a little bit more about that later. In locally advanced breast cancer, we oftentimes will treat the breast or the chest wall, depending on what type of surgery happened, and then the lymph nodes within that area, which kind of drain the region where the cancer originally started. So let's talk a little bit about COVID-19. We know, unfortunately, that the virus can be easily transmitted from person to person. And we know that having active cancer, unfortunately, increases your risk of severe illness. So the best way to prevent this illness is to avoid being exposed to the virus. And so in a radiation perspective, we think that decreasing the number of treatments equals decreased exposure. Luckily, this is something that we've been working on for the past 20 and 30 years. So how do we know that it works? There are two trials that are out of Canada and the UK that were done in the late 1990s and the early 2000s, which looked at decreasing the number of treatments that were given, but also increasing the dose of radiation that was given each treatment. So it creates what we call an equivalent biological dose. And both of these trials looked at going down from the previous standard, which was 5 to 6 weeks of treatment, down to about 3 weeks of treatment. And what the results showed was that there was no difference in local recurrence rates, overall survival, or cosmetic outcomes. Another way that we looked at kind of decreasing how much radiation we're giving is trying to reduce the amount of tissue that was radiated. So as I mentioned before, this is something called accelerated partial breast irradiation. And the initial studies for this used treatment twice a day for a week, so 10 total treatments. And again, they found very similar outcomes as far as cosmetic outcomes and also the ability to get rid of the cancer that was there. So when we looked at COVID-19 and how this might affect us in radiation, I think our department as a whole and kind of our specialty really looked at how we can minimize exposure without compromising cancer outcomes. So as I mentioned before, accelerated partial breast is less treatment, and that would be the traditional kind of twice a day 10 treatments. But there was also this new treatment regimen that had been used in Italy for over the past 10 years. And this uses only 5 treatments that are given every other day instead of twice a day. And so when we looked at 10 treatments versus 5 treatments can reduce your exposure, have you come in less. And so it's become our standard of care here at UC. The other thing that we looked at is that radiation boost, or that extra dose given around the area where the tumor started. And so traditionally we had done this after we had done the whole breast treatments, but there is some groups in a clinical trial that used that boost during radiation treatment. So instead of doing the 5 treatments after your whole breast radiation, we tried to give that during the radiation. And what we found was that the preliminary results showed very similar results. And so when possible, we've been trying to incorporate that into our practice here. And then last but not least, we wanted to come up with protocols for keeping our clinics safe. So these are things like wearing a mask, getting your temperature taken every day when you come in for treatment. And then also things like keeping our therapists at the radiation machine where they treat. We used to have them switch over treatments at times to kind of help each other out. And what we found was that that increases the exposure of that patient interaction with that therapist. So we've been doing that. And then we've also come up with COVID positive patient protocols. So unfortunately, cancer treatment is an elective. It's not something that we can put off. So if we do have a COVID positive patient, we've opted to have them treated at the end of the day and keep them separated from any of the other patients. And then undergo a rigorous cleaning process at the end of the day so that when our patients come in the next day, they don't have any increased risk of exposure. So kind of in conclusion, we really do want to provide the best care possible for our patients, but we want to make sure we use research to help guide those decisions. And so in the midst of this COVID-19 pandemic, that means keeping it as safe as possible to undergo treatment. We don't want anybody to miss any treatments just because they're concerned about their risk of COVID exposure here. And then also using evidence-based medicine to help decrease the number of treatments when it is appropriate.
Thank you so much, Sarah. So how fantastic that we were able to take the tough times of the pandemic and come up with something that's very good and very positive for our patients and for all of us.
Exactly.
You know, my patients at UC Health are so interested in new ways to treat them, but at the same time, sometimes they're a little scared about something that's new because their next door neighbor or their family member had the old-fashioned or the longer course. Are there more or fewer side effects if we give this shorter course radiation? How does that impact them?
So actually those clinical trials I talked about, it's really interesting. That was one of the hypotheses when they approached this, is by giving that higher dose of radiation each time, are you going to have more side effects? And what they found out was actually no. And in some of those cases, while it didn't turn out to be statistically significant, they did see a slightly actually lower number of side effects in the amount of patients who had experienced them on trials. So although different, it actually seems to be almost exactly the same, if not better.
What about this technique for everybody? Does this replace proton beam? Or, you know, we hear so much about our proton facility here at UC Health. Can you tell me if it's the same people that have proton, or is this the same as that proton, or how does it differ?
So proton therapy is actually using a different type of particle to get that high energy delivery into the body. And the way that the protons deliver that energy is just slightly different. It can be a little bit complicated, but essentially, basically, it delivers the dose before it hits a certain point, and then it likes to deliver a lot of its dose of radiation. There are certain situations where proton beam can be an advantage, mostly when you have a tumor that is laying right in front of something that you're concerned about, things like the heart, the lung, other things like that. Traditionally, our photon therapy has been used, and we've actually come up with great techniques that can equal that, but it is also very a specific case in which protons are better than the other cases. And also protons, we're working on making sure that we have the clinical evidence to say that they're going to deliver the radiation in this way and be as effective as it is before.
Certainly, I think we're learning more about proton and its potential role in breast cancer.
Yes.
So certainly if you're a candidate for a clinical trial in that, in proton beam, that's worthwhile. Yeah.
Exactly. Yeah. We have one open here that's looking at comparing photons to protons to prove that there are less side effects with protons than with photons.
Are there any patients that could not undergo this newer technique?
As far as the different delivery in the radiation, some of these shorter courses of radiation, the studies that have been done on this have a very particular group of people that this works for. In particular, some of our accelerated partial breast patients, even just where your tumor is located within the breast, can either make you a great candidate for it or not a great candidate. So it really is kind of the particular details of your cancer that may affect what course is chosen.
But certainly that's all part of the consultation when they meet with you or one of the members of your team. in our radiation oncology department. They will go over what is the best fit based upon your individual personal desires, but also location of cancer and things of that sort. So
exactly. Yeah. Each cancer is really a unique individual case, and we take it for that. Each person is different, and each cancer is different. So while these may be, offered for a certain person, sometimes they're not a great option for somebody else. So we go over all of that when they come in to meet with us.
Thank you so much. It's so nice to see that we were able to make actually strides during that early part of the pandemic.
Yeah,
so
it's one of the positive things I think that's come out of this is that, everybody is learning how to, deal with the pandemic, but also make sure that we're making very intelligent, educated moves in the process.
One final question. If you had that crystal ball, could you give us a prediction as to how long you think the pandemic is going to last?
So I think if I had this crystal ball, I'd probably be pretty rich.
That's so true.
As far as my guess, my hope really is that, by next spring or next summer, we're back to having a more, what we considered a traditional kind of view on the world and ability to kind of go out and do the things that we want to do.
More normal life, yeah. Thanks again.
Yeah, of course.
Yeah. So if you enjoyed today's mini talk, please stay tuned for next week. Because we will be again hosting a talk by Dr. Ryan Gobble, who will talk about minimizing infection risk in patients during plastic surgery. Today's talk from Dr. Medek, I think, enlightened us very much about how we can reduce the dose of radiation. And if you enjoyed it, please use your social media to pass this on to other friends, family members. We appreciate your support. Thanks again.